Oh, hi, Dr. Sabea. Greetings, everybody. Anyone want to say hi? Dr. Mutembai. How you doing? You look familiar. Have I met you before?
Yeah. I've been on your channel for some time.
Greetings, everybody. No, have I? I've seen you somewhere.
Yes. We've talked before.
Oh, okay.
Yeah.
Well, welcome.
Okay, thank you.
Hello, John.
Hello, how you doing?
I'm fine, thank you. How are you?
Oh, there we go. Okay, Dr. Sabea. Yeah, you dropped out there. You came in, you dropped out. How's it going? Everything all right? Yeah, I got the Kahoot all loaded up.
Good.
So I think I'll get better in that because it's kind of like tricky.
True.
But
we're having snowstorm in Amman, and we are all at home because we cannot go to work because of the snow.
Really?
Yeah.
Oh, wow. Okay. Do you know an African neurosurgeon approached me? He wants to start a French channel in neurosurgery.
Yep.
He says a lot of Africa is French. I didn't realize that. But we did have a webcast from a group in the Congo, and it was popular. It was a lot of French people there. It was all French.
True.
Because Africa, there's a lot of French.
Absolutely. Traditionally, historically, Africa has been very much connected to France.
Yeah, it's tight ties. And maybe we could get the French neurosurgeons to participate more, because there are certain groups that really we haven't touched, like German, French. And I appreciate you, opening up your part of the world.
Thank you.
So other parts of the world can open up too.
All the credit goes back to you, John.
Yeah, it's fine. We've got a good. Al Mefti, right?
Yeah.
Yeah, he has tomorrow. You go to the Brazil conference.
Yes,
they have one tomorrow. His son is giving it. You've probably seen that.
We've lost one of our very dear friends, Evandro de Oliveira. He's a very famous skull-based surgeon. He just passed away.
Yeah.
Just last week. It's a great loss for neurosurgery, and for me personally, he was a great friend and a caring friend.
You mean de Oliveira?
Yes, de Oliveira. Yes.
Yeah. I guess he hadn't been well for a couple of years, right?
Yeah. He had some transverse myelitis, and he was
Lou Gehrig's disease or something.
Yeah, something
progressive. Yeah, some type of degenerative spine disease. not spinal, degenerative disease. But yeah, Lewis is running tomorrow. And Lewis Borber, he's running it. He'll you know, I think you can go on the you can register and go on the channel because you participated. I've seen you there.
Yes, I did.
Yeah,
I did many
yeah,
times.
yeah. I think you can do that tomorrow.
Absolutely.
I think, yeah.
Especially that I'm home. We are confined at home because of the snow.
Yeah. Okay, we'll be back in a few minutes. We start in about 5 minutes. Okay.
No.
Okay, start in 2 minutes. Hi, Verdam. How you doing?
Hi, Dr. John. I'm fine. How are you?
Good. Good to see you. Now I'll just basically introduce myself, and then I'll introduce you. Introduce Dr. Sabea, but please say how long he's done education. 27 years, and now he's doing it online, digital, and basically explain his background. Okay.
Okay.
And I'll just basically say a few words, that's all. And then we got the cahoots, Pradab. I know that's why you came. Right?
Good evening, Professor Ibrahim.
10 difficult questions.
Yeah.
How are you doing, Dr. Ibrahim?
I'm fine. I'm at home because of the snow.
Yeah, we have snowstorm, Dr. John.
You know, the weather's funny here too. It's cold in the southern part of the country. Very cold.
Yeah, Florida is usually sunny. Yeah.
Let me just let a few more people in here. Everyone comes at the last minute. Okay, 10, 9, 8, 7, 6, 5, 4. Oh, well, let me remove the spotlight first. I always forget this. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. It's Dr. John Bennett broadcasting for Neurosurgical TV. Today we have the Jordan Neurosurgical Grand Rounds, and I'll turn it immediately over to Verdab, who's going to be the host. Hi, Verdab.
Hello, Dr. John. How are you?
Good.
Hello, everybody. Again, for the next week, for the second week, we have privilege to have Dr. Ibrahim Speh, well-known professor in neurosurgery in Jordan and in the Middle East, for his tremendous contributions to neurosurgery, and educational-wise and clinical-wise. He's been in education era since 27 years, and has been a second vice president for the WFNS. And so, Dr. Ibrahim, we are privileged to have you again this week and in this time to have a new topic presented by you. Thank you, Dr. Ibrahim.
Thank you very much. Thank you very much. We'll start now. Okay, so again, good evening, good morning, whatever time you have there in your country. I'm Ibrahim Speh. I'm transmitting from Amman here in Jordan, and funny enough, we have a snowstorm which is putting us at home rather than at work. And this is the Farah Medical Campus where I work. I always put to you this black iris, which is the symbol of Jordan. And we will continue what we started last week, which is the unusual intradural spinal lesions. Last time we put two cases. One of them was toxoplasmosis of the spinal cord, intramedullary lesion, and the other case was IgG4 pachymeningitis presenting as a tumor. Both cases were extremely rare and very unusual, and they can mimic any tumor. Today we'll continue the same. We will discuss two cases of unusual intradural spinal lesions. This is the slide also of the last week. My experience with intradural spinal tumors is 508, and today we'll be speaking about the others rather than the usual ones. So the first case is an extensive hemangioblastoma of the spine, and as usual we will discuss the clinical, radiological, operative, and pathological correlation. Hemangioblastomas is very unique. It originates exclusively from the central nervous system tissue. Very, very rare, if any, you find it in the peripheral nervous system. But it is unique that it is in the CNS. And it is grade 1, WHO grade 1. It is a benign tumor of the central nervous system, but of unspecified cellular origin. People, pathologists will discuss hours and hours of what is the origin, the cell origin of this tumor. Although it is benign, it can be very difficult. So the cells that people speak about in the this kind of pathology, stromal cells with lots of capillary network, neoplastic cells, endothelial cells, pericytes, mast cells, and with immunostaining, you'll have a lot of changes that you would not expect. So this is just to show you pericytes, lots of capillary networks, stromal cells, and mast cells. As you can see, they are usually very vascular. This is some of the cases I have removed inside it. So the classical picture of hemangioblastoma is a cyst with a mural nodule. But this is wrong conception because they can come in various forms and types. They could be totally solid and they could be totally cystic. So 70% are associated with cysts. Whether you are dealing with the spinal cord, you will find a cyst with a mural nodule, or whether you are dealing in the cerebellum, a cyst and mural nodule. But remember, this is not always the case. You may get totally solid tumor. So the types of hemangioblastoma, type 1 is totally cystic. This is very rare, 4%, totally cyst without any mural nodule. The totally solid is 27%, type 3. The common type is a cyst and mural nodule, it's about 60%. Sometimes you'll have solid with a very, very small, tiny cyst in it. So 4 types of hemangioblastoma depending on the cyst that is associated with the lesion. Males, unfortunately, are affected more than females in this disease, 2 to 1, unfortunate for us males. And the peak age is adult, 20 to 50. Rarely you see it below that or above 50. So hemangioblastomas as a presentation, they constitute about 2% of all intracranial neoplasms, but they constitute about 10% of the posterior fossa lesions or tumors, and they constitute 5% of all primary spinal cord tumors. So they are the third most common spinal tumor after epindemoma and astrocytoma. So the hemangioblastomas can be supratentorial. They can be in the posterior fossa, which is the commonest site, or they can be in the spinal cord. So let's see, do we get hemangioblastomas in the supratentorial? Yes, you do. So this is hemangioblastoma in the temporal area. This is paraventricular, and this is near the optic nerve, and this is supracellular. A very nice paper by Osama al-Mufti and his group from Arkansas at that time, hemangioblastoma of the pineal region. Another paper by Baskin and his group, and there is hemangioblastoma of the optic nerve. If we come to the posterior fossa, which is the commonest, you will find it in the cerebellar hemisphere in most of the cases, 65%. You may find it in the midline, 15%. You may find it in the cerebellopontine angle, 12%, or in the brainstem in 8%. So most of the time, they are in the cerebellar hemisphere as a cyst and the nodule. The brainstem, they love the medulla. They mostly come into the medulla. They can sort of 57% in medulla, 30% between the medulla and the spinal cord, and 30% between the medulla and the pons. This is one of my cases of the brainstem and the medulla, intramedullary. We have to differentiate between tumor or hemangioblastoma of the fourth ventricle, which is not touching the floor, and those who are buried inside the medulla, intramedullary brainstem hemangioblastomas. And I have 17 cases of these brainstem hemangioblastoma. As you can see, they are not kind of in the fourth ventricle, not touching the floor. They are all within the touching the brainstem. Those the 17 brainstem hemangioblastomas in various cuts. And the spine, and this is the topic for tonight, spinal hemangioblastomas, they love the cervical area and the thoracic area. So here we are, tiny small ones in the cervical region, single lesion here, multiple lesions here. Whenever you see a single lesion, this means this is solitary kind of hemangioblastoma. Whenever you see multiple, this is most likely a von Hippel-Lindau disease. And I'll come to that. So this is hemangioblastoma in the thoracic area. Here it is in the junction of the lower end of the cord, and here it's totally in the sacrum. So spinal hemangioblastoma, this is the normal and this is the cystic. They love this kind of the distribution. And if you look at it here, you would get confused where to start. They could be intramedullary, they could be extramedullary, they could be extradural, and they could be dumbbell through the foramen, part of it extradural, part of it intradural, or inside the canal. Various types of the hemangioblastoma here covered by the arachnoid. Once you remove that, you can see it here, we'll see it, and you can see the vessels. For me, and it must be for you too, you think of hemangioblastoma like an AVM. It has an arterial supply and it has a venous drainage. And you should deal with it like you deal with an AVM. So don't deal with hemangioblastoma if you have not dealt with an AVM. It is a must, because there are rules that you have to follow. You pick the feeders and then you leave the venous drainage till the end. So again, they can be on the sides, they can be on the surface, they can be ventral to the cord. So this is the easy one because you can see blood vessels are little and the venous drainage there. So if you cut the blood supply, you can remove it and leave the vein till the end. Here the same, hemangioblastoma with lots of blood vessels giving its blood supply. You go around it and you pick them one by one. You do not go into the mass itself. You should not go into the mass. You go around it like an AVM. What about do they grow? Whether they are solitary or part of von Hippel-Lindau disease, the answer is yes. They most likely they grow, but periods of growth are separated by periods of arrested growth. But all in all, there's not a single hemangioblastoma that did not grow along the line. And interesting enough, their growth is related to puberty, to birth control pills, to menopause, aging, and pregnancy. And if you think carefully, these are the same factors that cause the increase of the meningioma. Meningioma also increases in pregnancy and by birth control pills and so on. One of my cases, I saw her, 31-year-old female patient, I saw her in 1993 with these tiny hemangioblastomas and these tiny spinal meningiomas. At that time, her symptoms were mild, and if they are mild, you do nothing. You would not go and like woody woodpecker and go and pick all these ones because you just can't. So we waited on her. She did well. She gave birth to about 4 children, but then she came back to me 2003 with these lesions growing heavily. Again, here you go for the culprit. If this is the culprit, you go for it. You don't go and do the picker like removal of these tiny lesions. What's the treatment of these hemangioblastomas? First of all, you need an angiogram, like you need an angiogram if you are doing an AVM. Then you will think, should I do surgery, radiosurgery, or chemotherapy? Let's see. Angiography. Whether you are dealing with hemangioblastoma of the brain, or the brainstem, or the posterior fossa, or on the spine, angiography is very much needed because you will see feeders, you will see venous drainage like you see in an AVM. So here in this case, and it was noticed that it is totally solid tumor, totally solid, extremely vascular tumor, and it is in the brainstem. So all the difficult criteria there. And you can see here the blood vessels supplying it, and the venous drainage too. Cervical hemangioblastoma, you can see the drainage from the vertebral artery, the blood supply, and you can see it here. Or these two hemangioblastomas, and the angiogram would show you the feeders coming from vertebral artery, from the anterior spinal artery in particular. Another thoracic hemangioblastoma with this intercostal canalization, and you can see the feeders. Again, it's coming from the anterior spinal artery mainly. And this one in the sacrum, and you can see the blood vessels. So angiography is a mandatory investigations. People think about embolization. This is very vascular tumor. Why not to do embolization? Let's go through that. People would do embolization using particles or microspheres. They are injected into the feeding arteries like you do in AVM. But is it worth it, or is it safe? Let's see. I've done one of the cases, I brought you the slide of this embolization, and you can see it within the blood vessels of the tissues that we have removed, of hemangioblastoma that we have removed. So you can see the acrylic material and the microspheres inside the blood vessels. But mind you, if you do embolization, you may risk bleeding and infarction into that area. And this risk increases if you have a large size, 3 centimeters or more, or if you do angiography and if you do embolization. So once again, embolization is not without a risk. So some people would say, don't do it, it's not useful, because you are dealing with a small vessels, so you cannot really do it. And there is risk of hemorrhage and infarction. Let's see. Frederick and his group back in 1990 did one case of spinal hemangioblastoma, and they had massive bleeding and they lost the patient. So that speaks against embolization. Bernard George, a French skull base and vascular surgeon, very famous, with his work on the vertebral artery in particular, from Paris, published in Neurosurgery, June 2007, 3 cerebellar hemangioblastomas, 3 had hemorrhages. So again, the posterior fossa tumors are not good for embolization. The 3 died. And he had at the same time 4 spinal hemangioblastomas, and he had no hemorrhage. So this speaks with embolization for spinal angiography and embolization. So all in all, if you put them together, embolization is reserved for selective cases whenever there is a large solid and vascular lesions. This is personal choice. This is something that the surgeon himself or herself should decide. So embolization should be considered individually. The first line of treatment of these cases, once you have done the angiography and you knew your feeders and so on, is surgery. It's the first choice. And the aim of surgery is in-block excision. It is like AVM. You do not go and try to take the lesion from inside like you do with a meningioma or acoustic neuroma. You have to go around, pick the feeders, leave the draining vein till the end. So treat it as an AVM. And you calculate the feeders as close as possible to a tumor surface. So you can draining veins till the end and block excision. Again, never open it. A drastic bleeding would be difficult to control. And sometimes even just going around it, it can bleed. So I put a patty to sort of protect the lesion. Once it opens the surface, it will bleed like hell. Paper about the operative treatment of the spinal hemangioblastoma, the same rules like you do with hemangioblastoma of the brain or AVM of the brain. Examples of the surgery and what you do, but this is a small one. Although a lot of blood vessels, but this is a small lesion, so it can be excised totally. Again, here it's a small lesion and you can really go around it and dissect it. Here it's rather large lesion, but again, things can happen and you can go around it and remove it. This paper about intramedullary hemangioblastoma in urospine. Again, this is a nice case to do. Blood vessels are not much and it is a small size. People use ICG like you do with the meningioma, like you do with aneurysms, like you do with AVMs, to show you the feeders, which is a good trick if you have the technology there. And you can use, of course, the observation and the SSAB and the MEP, motor evocative responses, and the sensory evocative responses to see the progress. I don't use it as routinely, especially if the lesion is not related to the corticospinal tract. With excision, still there is a chance of 27% to come back again. What about radiation? What about if you failed to do surgery or you did partial excision, then radiation? It's a very good paper, and it speaks about stereotactic radiosurgical treatment of cranial and spinal hemangioblastomas. Let's see. 92 hemangioblastomas they reported. 26 of them were von Hippel-Lindau disease. They used the Cyper knife. They used the linear accelerator. They gave 23 grays to the periphery of the lesion. The mean volume was not large, so small, 1.8 cubic centimeter, and they followed them up for about 5 years, 6 years. Here, the result, 13 out of the 92 progressed. They did not really respond, so they progressed and they needed surgery. 18 out of the 92 regressed. 51 out of the 92 were stationary, and this is called control in the stereotactic radiosurgery treatment lingo. And 18 of them had radiation necrosis. So all in all, it's not that good. Though the conclusion of the paper was stereotactic radiosurgery is safe and effective. To me, this contradicts these results. Another paper from Japan about radiosurgery use of the intracranial hemangioblastomas using LINAC-based radiosurgery. They've used 10 to 40 grays. There is some decrease inside, but it does not disappear. Don't expect it to disappear. What about chemotherapy? Useless. People tried many chemotherapeutic agents without any success in hemangioblastomas. What about future treatments? Angiogenic therapy using interferon alpha can give you some tumor stability, but it will not eradicate the tumor at all. As I said previously, that these hemangioblastomas, whether cranial or spinal, they can occur as solo or as part of von Hippel-Lindau syndrome or disease. Which is the commonest? The sporadic cases are the commonest. The von Hippel-Lindau syndrome are the minority. About 30% von Hippel, 70% are sporadic. So 20-30 are von Hippel, 70-80 are non-von Hippel. What is this von Hippel? And this is a very good paper for everybody to read. What the neurosurgeon should know about von Hippel and about the sporadic and von Hippel-Lindau disease. So we're talking about two people, von Hippel and Lindau. Von Hippel, he first discovered the retinal hemangiomas or hemangioblastomas, and Lindau discovered the CNS. So they combined their efforts together, and we speak about von Hippel-Lindau syndrome. This is Eugene von Hippel, a German ophthalmologist who discovered the retinal disease, the retinal lesions, back in 1904. While David Willem Lindau, a Swedish pathologist, he discovered the CNS lesions. And that's back in 1926. And they coined the term von Hippel-Lindau disease, and we thank them for their efforts. They served humanity by discovering this disease. Von Hippel-Lindau is an autosomal inherited disorder. Why does it happen? Loss of function of the VHL, von Hippel-Lindau gene. So you are prone to many tumors. And if you have the disease and you transmit it to your children, that's bad. It will remain in the family. 50% of von Hippel-Lindau patients, they have an affected parent. It affects the whole body, the brain, the retina, the pancreas, the kidneys, the epididymis, the suprarenal, and so on and so forth. And people speak about two lesions or a disease and a syndrome, von Hippel-Lindau disease and von Hippel-Lindau syndrome. So this is called type 1 and this is called type 2. Type 1 is the cerebellar and extra CNS in retina, for example. A syndrome is VHL disease plus endocrine tumors. So differentiation between a disease and a syndrome. Once you get the von Hippel hemangioblastomas, they are multiple. You have seen some of the MRIs I showed. Once you see multiple hemangioblastoma, this is von Hippel-Lindau disease. So this is a benign tumor that can turn malignant, not forgetting the difficult sites it occurs in. It can really metastasize like any malignant tumor. And they have higher incidence of spontaneous hemorrhage. Look at this, retinal hemangioblastoma, as I said, discovered in 1904 by von Hippel. Is this the only thing that the von Hippel affect the retina? No. It can give the patient a retinoblastoma. It can give the patient a retinal melanoma. It can give the patient a retinal AVM, retinal telangiectasia, a retinal aneurysm, and retinal cavernoma. It's a very drastic disease. And as you see, those patients would lose their eyes. It can affect the kidneys, renal carcinoma. It can affect the suprarenal by giving us phaeochromocytoma. Imagine that you have a hemangioblastoma and you don't know whether this is part of von Hippel. You put the patient to sleep under anesthesia and the blood pressure would go malignant and he will die on table because you did not realize that this von Hippel disease is associated with phaeochromocytoma. It can affect the pancreas, pancreatic carcinoma, and it can affect the endolymphatic sac by causing endolymphatic sac carcinoma. It can affect the epididymis by causing the epididymis adenoma that can turn to a carcinoma. So how can you diagnose von Hippel so long as it's a serious disease, whether it is disease or syndrome? You need two CNS lesions, cerebellum and spinal cord. So this clinches the diagnosis. What about if you don't? So the other clue for diagnosis is or one CNS or one retina plus one visceral, pancreas or kidneys or whatever. So once you have this, two CNS lesion or one CNS with visceral or one retina with the visceral, this is clinching the diagnosis. But once you get there, you don't stop. You have diagnosed that this patient has von Hippel. So you have to go back to the roots. You have to go to his family. We're remembering that 50% of those patients have unaffected parents. And I have the cases that I showed you, a miserable Jordanian family that the mother was affected and two of her male sons were affected. You need to do full ophthalmological examination. Excuse me. Why? Because 50% of those von Hippel have ocular manifestations. And remember that 10% of them, they end in a ciliation of their eyes. These are two of my patients, two Jordanian female patients with artificial eye. And you can tell that this is artificial eye and this is an artificial eye. So when they came to me with their CNS lesions, cerebellar in particular, they have already lost an eye for retinoblastomas. You have to go and do the screening protocol. You have to do brain and whole spine before and after contrast. Don't go for contrast. You have to go for before and after. Some radiologists, they just to spare some money, they do the test with contrast. This is wrong. It has to be done before and after, and you have to specify this in your request. CT abdomen and pelvis before and after contrast. CT chest before and after contrast. And you have to collect urine, 24-hour urine for catecholamines, for vanillyl mandelic acid, metanephrines, and so on to exclude the possibility of phagochromocytoma, a disease which if not diagnosed, it will kill your patient once he's put under anesthesia. So now we have discussed what is hemangioblastoma of the brain and of the spine. I'm going to present to you this case of an extensive hemangioblastoma, and again discuss it from the clinical, radiological, operative, and pathological points of view. This is a girl, 15-year-old from Bahrain, who came to me with this very miserable history. Look at this. Since childhood, she was walking on the tips of her toes. Funny enough, she was diagnosed to have rickets. She did not have rickets. She had extensive hemangioblastoma of her spine since childhood. 5 years following that, just before she came to us at the age of 10, she started to have back pain. She has starting worse working abilities. And when she came to us, she gave us history of age of menarche at the age of 9 years, and she had irregular menses and dysmenorrhea. Could this be related? We'll see. Examination shows hypertrichosis. You can see these lesions in her forehead. She had hirsutism. You can see the hair in her arms and her back. And her neurology showed severe weakness in her lower limbs, slightly in her upper limbs, but mostly in her lower limbs, with upgoing plantars and brisk reflexes and a clonus. And look at her MRI. This is extensive lesion extending all the way through the cervical cord, through the thoracic cord, and down below. You can see the lesion, serings, multiple serings. The cord is mixed with the lesion. So serings of normal dilated cord filled with something. And if you follow this dilated cord with lots of blood vessels and you cannot differentiate, there is some localized contrast enhancement. But this does not mean that this is the only lesion, because I will show you once we go, like here and here, the lesion is extensive. It's taking the whole cord. And this is the unique aspect of this case, because we did all the von Hippel-Lindau markers. This was a sole lesion. She did not have a von Hippel. She did not have a family history. She did not have any chest or pelvis or abdominal lesions. Sole, total spinal hemangioblastoma that was so much neglected. Look at this. Blood vessels, serings, the whole cord and the whole even coda equina is affected. Same thing here. And this is the whole spine for you to see. If you take a transverse section, you can see this, and you can see with contrast, filling the spinal canal. Again, you cannot differentiate a proper nervous tissue. It's a mixture of these of this tumor with the spinal cord. And let me read with you the report of this spinal MRI with and without contrast. The whole spinal canal is occupied by the tumor with multiple serings from the lower medulla to the conus medullaris. Even the coda equina could be seen involved with this lesion. After IV contrast, there is a patchy enhancement along the whole of the spinal thoracic cord. There is a vivid contrast enhancement opposite T11 to L1. There are extensive vascular voids above and below the lesion. The whole spinal cord is expanded by the lesion, which is a mixture of solid enhancing lesion, partially or completely, cord edema, cord congestion, AV shunting, and vascular voids. What more do you need? Once you see this, what is the differential diagnosis? Although it looks like hemangioblastoma, but let's see how extensive the differential diagnosis is, especially that she did not have any von Hippel-Lindau syndrome or disease manifestations. Epindemoma can look the same: astrocytoma, subependemoma, oligodendroglioma, enterogenous cysts, epidermoid and lipoma together, schwannoma, ganglion neurocytoma, Hemangioblastomas, of course, on the cards, cavernoma, especially if they are multiple. And I have recently, last week, a case of Jordanian patient, which was very strange, with what seems to be familial cavernomas filling all of his spine and his brain. Multiple sclerosis, tuberculoma, a dural arteriovenous fistula, so vascular lesion. Could this be dural fistula? Could this be an avium? Especially there is shunting here in this case, radiation-induced neuropathy or myelopathy. Lymphoma can mimic any tumor. Transverse myelitis. So we asked the opinion of our endocrinologist, Dr. Muhammad Juma, and he said, well, she had early menarche at the age of 9, but she has also hirsutism and hypertrichosis. And he diagnosed this as a familial hypertrichosis. She had high prolactin level, so he asked us to do pituitary MRI, and we did, and indeed she had a pituitary adenoma. So this is the combination that you see sometimes of a hemangioblastoma and pituitary adenoma. It is not rare. Of course, we did, as I told you, all the other criteria for von Hippel, and it was negative. And I looked into the literature to see, can they coexist? Can hemangioblastoma coexist with pituitary? Yes. I found a few papers, and this is one of them, coexistence of pituitary null cell adenoma with von Hippel-Lindau gene. We asked our interventional radiologist, Dr. Hazem Haboob, to do the angiogram, and he said that I found dilated arteries and veins very much away from the cervical region and thoracic region, a huge vascular soft tissue mass in the lower dorsal spinal region, supplied by branches of the anterior spinal artery, right L1, left T12, right T12, anterior radicular branches. And you remember the artery there is important. The Adam McQuick is very important to recognize. And he did vascular embolization, but when he came out, he was not happy. He said, I could not really do much. It was impossible to do to close the feeders. So very few were selected and embolized. And he wrote this in his report. Only very partial embolization was possible. So what to do? This is the report, as I said. And this is the angiogram. You can see the intercostal blood vessels and the flush of that is the lower thoracic area, and his attempt at embolization. But as I said, this is a very formidable lesion to treat. And I was at loss, should I operate upon her or not? I felt that if the radiologist, intervention radiologist cannot do embolization, most likely I will not be able to. But again, this is a 15-year-old. Let me give her whatever chance I can. So I took her to theater, but with a faint heart. I did not think much I can do for her, but still I want to really explore and see. And this is what I found: a whole congested, dilated edematous cord where you cannot differentiate between the cord and the tumor. I ended just doing a trial, and this trial gave me the clue that you just cannot continue, so I stopped. And I did a baggy closure of the dura so that I will give her some expansion, because when I opened the dura, the whole cord came out under pressure. So let's see the surgery for this case. Again, not much. Not much to see, but again, can you see the video? John, can you see my video?
Not yet. It's just
Okay.
the surgery.
Okay, let's see.
Start it again. There we go. We can
Okay.
see it.
So as I said, this is the opening, and I just go through that. Notice that once you open it, and this is the way I open the dura, holding 2 forceps. You can see the spinal cord just came out. Again, there's no spinal cord tissue to see. So finding the midline, I calculate there. I did not want to go across those blood vessels. Immediately, it's bleeding. I try again, bleeding. I knew then I just cannot find any plane of cleavage at all. Again, here widening the opening, you just can't. So I took a small piece of tissue and I used this artificial dura to cause a very baggy closure of the spinal canal. Okay. Okay, so the histopathology of the material that I removed, I sent it to our histopathologist, Dr. Hassan Farsakh, an American fellow of pathology from the States. We've been dealing with these lesions together for decades together, and he reported as Hemangioblastomas grade 1. And this is really a pity that Hemangioblastomas grade 1 would remain for 12, 13 years in the spinal cord of this unfortunate child without anybody noticing. Again, the same histopathology that I described: stromal cells, capillaries, large vessels, hyalinized, and so on. And these are the immunohistochemistry: GFAP negative, pancytokeratin negative, CD56 negative, VGF is negative. She did not change much after surgery, lucky enough. And I discussed it with her family, and this is what I wrote in my final report. This is a badly neglected case of extensive inoperable spinal hemangioblastoma. Nothing can really be done further. Attempts at radiation by cyper knife in Turkey, which I discussed with them, and they took her to Turkey for cyper knife. But since she went there, I did not hear much from her. The next case is an extensive epindemoma. Again, in my series of 508 intradural, I have extensive experience of 113 of ependemomas, but this one is not like any other one. So this is the normal, this is the epindemoma because it is in the center of the lesion, center of the spinal cord. And if you look at the papers discussing the pathology of these spinal ependemomas, they would give you 3 grades: grade 1, grade 2, and grade 3. Of course, grade 1 is the best, grade 3 is the worst. And even this is reflected on the prognosis of these cases and how they behave in the future, because the recurrence rate is high, the possibility of accession is high in grade 1 and very low in grade 3. And this is the Kaplan-Meier analysis of these lesions, whether you are dealing with a grade 1, grade 2, or grade 3. You can see the survival of these cases, the progression-free survival. So it is worse with the grade 3 and better in grade 1 and 2. So you may go in this case for radiotherapy if you cannot remove the tumor completely. But if you do gross total resection, don't jump for radiation, just wait If there are major recurrence, then you re-operate, and if recurrence, then you can send for radiotherapy. This patient is a 13-year-old male patient from Iraq, very lovely child, with this extensive lesion. It's involving the medulla and whole of the cervical cord. This is in the coronal views. Again, here you can see the part of the lesion inside the medulla oblongata, expanding the medulla, and you can see the lesion and you can see the settings associated with it. Usually this is taken as a sign of hemorrhage into the upper pole of the lesion, and usually this is taken as a sign that this is most likely an epindemoma. Though I remember the words of Jack Brocci, who always would tell us that don't trust the MRI to say this is astrocytoma or epindemoma. And when you open for radical excision. You don't open for biopsy. Biopsy, in the book of all of the good spinal neurosurgeon, is to be condemned, biopsy and radiation. So here is the expansion by hemorrhage of into this lesion. As I said, this denotes a prior hemorrhage. You can see the cord is expanded completely. You can see the expansion of the medulla. And you can see fluid level. This was a fluid, sort of CSF-like fluid, and this was blood within the medulla. So here we are. This is the expansion of the medulla with the fluid level, expansion of the spinal cord, and so on. Not much of neural tissue is left. The whole thing is occupied by this extensive epindemoma. Again here, I would not open just to take a biopsy. I would do complete exposure of the spinal cord along where the contrast lesion is. And in this case, I did it in the sitting position, and we are very experienced with the sitting positions. We have done thousands of these, and we don't have complication of air embolism. Maybe the first case I've done in Jordan had air embolism, but then over the last 30 years, there is air embolism, but we can treat it and we can eradicate it. Let's see the surgery again. I hope this time it will work. Can you see it?
Not yet.
Not yet, okay.
No.
What about now?
No, yes.
Okay. So again here, to find the midline is something. I may discuss this next time, how to find the midline. This is called opening of the posterior sulcus. If somebody call it myelotomy, it's wrong. And once you open it, you can see the blood vessels and you can see the lesion. So there is a very good plane of cleavage between the spinal cord tissue and the epindemoma, because I opened it completely along with the whole length of the enhancing tissue. And being in the sitting position, that helped me a lot. You can see, I'm not going for biopsy here. There's a good plane of cleavage, so let's use it. And you cannot see that plane of cleavage unless you dare to look at the whole lesion and open a very good opening. So it's almost coming out, and I just kept it dangling like this and went to see the upper end. Very extensive lesion. No radiotherapy can eradicate this at all. So we're reaching here to the upper limit, but still we have the hemorrhage here in the medulla. Always you find a small, tiny feeder here that you can coagulate, but don't use the cautery or diathermy unless it is very needed. Like you do with an acoustic neuroma, or like you do with the meningioma, you just dissect it from the surrounding tissue. Here I did not use the ultrasonic aspirator. I used the usual scissor. it's a big, huge lesion. And you can see that if you just took a biopsy and give the patient radiotherapy, you have not served him good at all. In fact, this is considered as a crime against humanity just to take a biopsy and send for radiotherapy. Again, here's the last piece. So the cord is open like an open book. Once that is done, I've gone to the upper end and trying to find the hemorrhage into the medullary cystic part. Here you are. So our diagnosis was correct. This was the upper pole of the tumor, and there was hemorrhage that reaches up to the medulla. So here I'm trying to remove the last piece that is going up to the medulla. And you can see here the cord and the closure. And again, I may discuss this later in another session, how to close and how to open. We'll do it next week or whatever. So, again, the tumor was sent to Dr. Hussam al-Farsakh, and he diagnosed it as Epindemoma grade 2. Again, grade 2, but we have done radical excision, so there's no need for any radiotherapy or whatever. These are his slides, Nistine showing glial processes low, Ki67, GFAP positive, and so on. This is the immediate post-op. You can see that the hemorrhage into the medulla is removed, and the whole spinal cord is again having a good time. And the serings in the upper part and the lower part is getting less. So you can see the huge serings is almost disappearing. So again, this is the message to take home, that you go for gross total resection of these lesions. Never ever go for biopsy and radiotherapy, and never ever diagnose based on the MRI. Never ever open on a small opening, because this means to me that when you open this small opening, you are just going for biopsy, which everybody is against. And this is the boy doing well, etc. I think I'll stop here, John, because time will not allow us to do the questions, and not enough to do the Kahoot questions. And next week, we'll continue with more of these unusual spinal lesions.
Thank you, Dr. Ibrahim, for this spectacular, fantastic presentation. Actually, it's a very informed and educational and highly educational lecture for us. We're very privileged to have your shared experience with these considerable to be a rare neurophysical lesions. Dr. John, do you have any comments, or would you like to say anything?
No, that's okay. Any questions from the panel? Just handle the discussion, Rita, okay?
Yeah.
Anyone have a question or comment they'd like to say?
Again, I can see in the panel, Dr. Hussam al-Farsakh, our histopathologist. If you are there, Hussam, can you please give us your input into the histopathology of these two lesions, the hemangioblastomas and the ependymomas? Also, I see Dr. Sami al-Khatib, oncologist, radiation oncologist. Again, Sami, if you are around, please give us your input about radiation of these cases and what your experience tell us about it.
Hi, Dr. Ibrahim.
Hello, Dr. Hussam al-Farsakh.
Yes.
So please.
I would like just to comment on the hemangioblastoma case, which was a very weird case which on the spinal cord. Most of the hemangioblastomas that we did actually was in the cerebellum, but this case also was unusual in the spinal cord and was extensive. And one of the things that you always emphasize that we don't do biopsies in the tumors because you have to remove the whole tumor. And this tumor was probably the only one that you could not remove the whole tumor, and you got the small biopsies of it because of the very extensive nature of the tumor. And I remember your comment that nobody can do a good excision of this tumor because of the wide extensive nature of the tumor. So this was really a very weird case, and I think it's worth publishing this case in the literature.
Sure.
Thank you.
Thank you, Hassan. Thank you very much.
I'm Sami Khatib. Thank you, Dr. Ibrahim Sbeh, for the excellent lecture. I'm really happy always to work with you. Are you hearing me?
Yes,
Yes.
we are.
Yeah. So I'm really happy working with you because usually you give me the cases very clean and very easy. So I have a good success on my work due to your job, due to your good job. So I agree 100% with you, mainly regarding the first option of these lesions is the surgery. Never should be only biopsy and send it to us. For grade 2, I agree with you. No radiotherapy unless we have a recurrence for the lesion, and sometime for grade 3 we can do it. As you presented, we have almost about 70% in radiotherapy between local control and good regression. But I confirm again that first option for these lesions should be surgery.
Thank you, Sami. And I'm just asking for all the panelists there, and when is the time that head of departments would tell their residents that this is the wrong practice to do, a biopsy and radiotherapy? Dr. Sami, you are oncologist. You would love us to refer cases for radiotherapy, but you don't love us to refer cases with a huge volume of the tumor because this would sabotage your efforts of radiation. You will be giving radiation for a huge volume of tumor, so there is no success. Success in radiation depends on very little amount of tumor left. So when are we going to put an end to this? When are we going to put an end to the wrong practices, which is not only in Jordan, but all over the world? People should stop doing this biopsy and radiation, whether this is a spinal tumor or a brain tumor. Thank you, Sami, for your comment.
Thank you, Dr. Ibrahim. As usual, excellent lecture.
May
Really,
I speak, Dr. Ibrahim?
Yeah, please, Dr. Ala. Dr. Ala is also an oncologist and hematologist with a vast experience. Please, Ala. Ala, go on.
He was on there.
Yeah, he was.
Ala, maybe you need to unmute yourself.
Yes, yes.
Thank you. Thank you so much for your wonderful presentation, Dr. Sbeh.
Thank you.
May I echo the importance of attempting total excision of these cases, because if this is attempted, these patients are doomed. Their best option is the surgery, proper surgery at the get-go. And if they do not have this opportunity, no good radiotherapy can fix that, and definitely no good chemotherapy can fix that after that. Now, as you have mentioned, and when we were discussing the Hemangioblastomas scenario, there's a lot of talk about angiogenic therapy as an adjunctive therapy post-operatively, but to cut down the lengthy anecdotal experience, these agents basically do not work, particularly if the lesion is still in situ or has not been cleared. The radiation oncologist is, as my dear colleague Dr. Sami is, no good radiotherapy, and I'm sure he would concur, would fix a mediocre surgery in the beginning. And definitely no good anti-angiogenic therapy in hemangioblastomas would fix a lesion if not properly dealt with surgically at the get-go. Now, when it comes to epindemoma, the same scenario holds. Epindemoma, as a medical oncologist, there are options we can offer. Usually the options are cisplatin-based. And this is after good surgery and after radiotherapy. And radiotherapy in that scenario would probably be craniospinal. You may want to elaborate upon that. But adjunctive therapy post-surgery and radiotherapy in ependymomas would be mainly cisplatin-based, cis-etopsad or the like regimens. There's a lot of difference between peds and adult trials. Though a lot of them are inspired by pediatric literature. Again, I cannot emphasize more the importance of proper surgery in the beginning, because if you don't offer these patients proper surgery in the beginning, no good radiotherapy and no good chemotherapy would be able to fix that, and the patients would be doomed to a course of recurrence and horrible morbidity before they ultimately die. Again, allow me to thank you for this wonderful presentation, Professor Speh. And
please go on. Ala, are you there?
He seemed to drop off.
Well, thank you, Ala, for your comments, and we are always having the pleasure of your comments because they are accurate and to the point all the time. There is a question on the chat. I can't remember which did it come from, but the question was, did you do laminotomy or did you do laminectomy? I've been a neurosurgeon for the last 35, 36 years, and I've used both. But you are torn between two things. First of all, I never go to the articular surfaces. I just remain off the joints, so there will be no kyphosis and no instability. But again, in a child, you would need to do laminotomy. So I use both, but there is a risk of pressure on the cord and laminotomy and bad healing. And there is the risk of kyphosis in laminectomy. So one has to choose. I have used both techniques.
Well, thank you, Dr. Brahim. May I ask you some questions? Actually, I have maybe one or two questions. Well, first, did you need to do any neurophysical monitoring intraoperatively using the Bayer for that medulla lesions and the SSP or the motor evoke potentials during the two operations, one for Hemangioblastomas and Epindemoma?
Yeah, if you look into literature, you will find people split between using them or not. So I don't use them routinely, to put it in a nutshell. They sometimes can be misleading, but sometimes they can be useful. The neuromonitoring in the brain is far, far greater of a help than in the spine and neuromonitoring. And again, how can you test the motor evoked responses if the region is posterior to the cord and not anterior? So there are points of view here, but basically I don't use it as routinely.
Okay. And my second question is, what about that Hemangioblastoma? Was there any rule for the polycythemia in the patient, or it was not related or not even?
Oh, yes, it is. If you go deep into in fact, of all these series, large series of mine of hemangioblastomas being cranial or brainstem or the spine, I have seen polycythemia in only 2 cases. Polycythemia vera. But it is there in the textbook that you should look for polycythemia. And the other thing to remind you to look at is high arched feet. All those patients with hemangioblastoma, they have high arched feet. They don't have flat foot, they have high arched feet. So part of my examination in my clinic, I undress them, take their socks off and look for their high arched feet.
Okay. And my last questions, I'm just eager to know what was the end outcome for that patient with hemangioblastoma. did she had end up with
Yeah, as I said, we arranged for her to go for a cyber knife. We don't have cyber knife here in Jordan, so I arranged for her to go to Turkey, but I have not heard from her. I have their Bahraini phone number. I tried to contact them. They did not answer, so I really don't know.
Okay. Thank you, Dr. Ibrahim.
Excuse me, Radab, there's one person that comments, but you can do laminoplasty.
Yes.
Okay.
Yes. Yeah, of course. Yeah.
Okay.
Maybe Muhammad commented, please, practical landmarks for myelotomy. I know.
What was the question?
Maybe he's commenting or he's just asking for the landmarks of the myelotomy. I don't know it's what's a comment or a question.
Yeah, I think that's what he means. Yeah.
Yeah, it's your experience with how far the lamina goes and where the articular surface, the facet joints are. So this there's nothing called landmark. It is what you see and what you know of your MRI images and of the plain X-rays of where to stop when you are doing the laminoplasty. Yes.
Okay.
The question was about myelotomy. Yeah, myelotomy. The question was about myelotomy. I answered the wrong question. Myelotomy is where to open. First of all, I'm against the terminology. We do not use the word myelotomy. You should never do a myelotomy. We open the posterior sulcus. There are two sulci, one posterior and one anterior. So we open the posterior sulci between the gracile and cunate on one side and gracile and cunate on the other side. If you do myelotomy, you will go into the gracile and cunate and you will cause complete loss of joint position sense. So what you do is to define the midline. The question is how to define the midline. Easy. First of all, you look at the area where the rootlets are coming out on both sides. So you see them and then you take the midline. The other thing is to, of course, when there is a tumor expansion, you may lose that landmark. The other thing is to look at the blood vessel. There is usually a blood vessel that is going around in the midline. So you try and open it there, and then gradually you open the sulcus, and you know you are in the sulcus once you see these vessels going into the cut surface. You see them, so you know you are there. These are preserved vessels on both sides. So these are your landmarks. I hope you answered your question.
There's another question from Abu Bakr Shomo. Do you want to ask directly, Abu Bakr?
Hello. Thank you for Dr. Ibrahim for a great presentation as usual. My question, actually, if the spinal cord, epindemoma is not totally excited, is it necessary to do radiotherapy or some sort of chemotherapy or like that?
Yes, I mentioned that, but it's no problem to mention it again. If you do gross total resection, and you know you have done gross total, meaning that you have left some tumor. In the case I presented, we did not leave any piece of the tumor. But in case where you did a gross total resection and you felt that you have left something, you don't give radiation, even if it's a grade 2. You just wait. If it recurs, don't give radiation. You go for another operation. Spinal surgeons would go 3-4 times for excision of these lesions, and they leave radiation till the end. Radiation is not something easy to just drop patients to. If it recurs after that, then you can give radiation. So don't jump for radiation immediately. Wait and see.
Thank you.
Very good. Where are you from, Abu Bakr?
Yeah, I'm from Sudan, but nowadays I'm in Ankara, Turkey.
Okay, welcome.
Yeah.
Welcome anytime.
Thank you.
Okay, Radab, I think we got most of the questions. Do you see any in the chat, Radab?
No, actually, Dr. Ibrahim has answered all the questions in a very informative way. Thank you, Dr. Ibrahim.
Pleasure.
Okay, I think we're ready. Are you ready, Radab, for the Kahoot? I don't know. You couldn't sleep last week after the last one you said. Okay,
I think I had the third grade, third place last time.
Yeah, I bet you bragged about it all week. Okay, Dr. Sabea,
Yeah.
are you ready? We're going to
I'm
play
ready.
this. Okay, let's go. And Dr. Sabea made these, cut these questions together. And let me just get the Kahoot going. Just give me a second. Okay. No, hold on. I'm sorry. Okay. Okay, I apologize. I should have been ready for this. Okay. Okay, here we go. Okay, I'm going to share the screen now. Okay, and now this is the go to Kahoot, as you can see in the screen. You can see it on the screen, right, Dr. Sabea and
Yes,
Radat?
yes. Yeah.
Okay, you can see that. Go to the kahoot.it, and then you put this number in. Okay, which I'm going to do right now. I hope Radat does it too. And Dr. Sabea, if you want to join in, you're welcome.
Thank you.
I'm going to take my smartphone. I'm going to go to Kahoot. Kahoot.it. That's why I hear one person coming in. It'll be a minute or two. We'll give people time
Sure.
to check in there. Now this allows people watching to participate, which is convenient. You can get their input from wherever they're at. They don't have to necessarily be in the panel. Okay, we're picking up some more people here. I'm logging in myself, so that'll be another person. The game pin, 340. I'm punching in 1, 2, 6, 7. Okay, I'm entering in myself, asking for a nickname. Okay, I got it. So I'm in there too. 2, 3, 4, 5, 6. That's excellent. That's excellent. Okay, I think we can start. Okay, here we go. It's self-explanatory. You pick one of 4 choices on your smartphone. Okay. Infantile Hemangioblastoma is commonest in. Now vote on your smartphone now. Okay, 3. Now
Yes.
is that the right answer?
Yes, it's correct. And as we mentioned that supratentorial is less than infratentorial. When you say infratentorial, we mean the posterior fossa and the spinal cord, and all of these, the commonest in the brainstem is medulla oblongata, then the brainstem.
Okay,
So this is the correct answer.
Very good. 3 got that right. Okay, we'll see who jumps to the lead. I bet you it's for Dab. Okay, Jolly Hamster, we won't identify who was who yet. Let's go on to the next question. And again, it's, can you see?
Yes, yes, we can.
Yeah, you can see okay? Okay. Okay,
Again, here the correct
all of the
answer.
above.
4 is the correct answer.
Oh my God, we got some good students today.
That's right.
Okay,
So
very good.
just to explain it, that spontaneous bleed is one of the risks that one take if one is doing angiogram or embolization. So it's important to realize that.
Very good. Okay. Next question. We'll see who tallies up to lead. Diligent picks. We won't identify anyone yet. Okay. Dumbbell tumors include again on your smartphone. Okay.
The correct answer is all of the above. Traditionally, people think of schwannomas as the only dumbbell tumor, so as if we have extraspinal and then through the foramen into intraspinal. This is the wrong conception. As much as schwannomas can do that, meningiomas can do that, chordomas can do that, chondrosarcomas can do that. So don't think of dumbbell tumors as just meaning schwannomas.
Very good. Okay, we're still on a roll. Soaring horse jumps to the lead. Okay. Schwannoma spine, which is correct. I may have not put that right. Schwannomas of the spine.
Yeah, it's okay.
Yeah. Okay, all of the above again.
All of the above is the correct answer. All of these statements are correct. Schwannomas usually are intradural extramedullary, but they can be totally extradural. They can be dumbbell, as we mentioned. So all of the above is the correct answer.
Okay, very good. I think this is our best group of students. Okay, soaring horse. Von Lipo-Lindau syndrome, which is correct? Okay, correct answer is C.
Yeah,
it's more common in males than females. Is that correct?
It is commoner in males.
No, I'm sorry. A is the answer, right?
Exactly.
So,
that's what I'm saying. A is correct and C is
okay.
correct. Yes. So
Okay.
A is correct and C is correct because it's commoner in males and it is an autosomal inherited disorder.
Okay, two correct answers in that one. Okay, very good. Okay, who's they hold on to the lead. Okay, next question. Von Hippel-Lindau syndrome may include okay, all of the above again.
All of the above is correct because it includes the retina, the brain, the spinal cord, the pancreas, the suprarenals, the kidneys, etc.
Very good. Okay, let's see how that tallies up. Stay diligent. Ben stays in the lead. Screening protocol for von Hippel-Lindau syndrome include, I spelled that wrong. Okay,
Again, all of the above is the correct thing. It's just to remind people that von Hippel-Lindau disease is a serious disease, and if you are not aware of what are the systems that is affects, then you would not be able to do the screening proper. So abdominal CT scan, chest CT scan, pelvis CT scan, and the family screening, the 24-hour urine for vanillin mandelic acid, all are needed to diagnose. And if you fail to diagnose that, you will pay the price.
Okay, that's good input. Okay, let's see how we go here. Maintains the lead. We're getting down to the wire, 8 of 10, this number 8. Spinal ependymomas constitute. Constitute, there's a couple answers there. Which one's C?
The correct
40%.
answer, yeah, the correct answer is C. Ependymomas and astrocytomas, they are the commonest tumors, and the rest comes by. So as I said, maybe 50%, 50%, but definitely 50% for ependymomas, 50% for astrocytomas. So ependymomas constitute something roughly of 40%.
Very good. Okay, maintains the lead. Diligent, Bex. Extent of gross total resection of spinal ependymomas, which is correct. Okay, all of the above again.
So all of the above is the correct thing. Let's look at them one by one. If you do gross total resection for different grades of ependymomas, the best you can achieve is in grade 1. You can achieve gross total resection like the case we presented in 70% of cases. If you have grade 2, you may be able to do gross total resection in 55, but in grade 3, this goes down to 30%. So grades of ependymoma can sometimes dictate how much gross total resection you can do. The best gross total resection is in grade 1.
Very good. Okay, let's see if Diliband maintains the lead, even widens the lead. Down to the last question. Someone's really going to have to get a lot of points to beat. Pediatric population ependymoma is. That's a tough question.
It is.
Okay, it's two the incorrect. That was the only incorrect answer.
The
Okay.
correct answer is A, because in pediatric population, cranial ependymoma is far, far commoner than the spinal ependymoma, in contrast with the adults. Others, they are almost the same. But in pediatric, and we all know that the commonest of the tumors in the posterior fossa in pediatric age group is ependymoma. So in ependymomas in pediatric age group, it would be 10% in the spine, 90% in the cranium.
Very good. Okay, drum roll, and violins are up for the final tally. And we may even ask the identity of the winner after. But the winner can stay anonymous if they want.
Of course.
Okay, looks like, oh my God, 7 out of 10. That's pretty good. The best of all. Does okay, Verdab, are you that person?
Yeah, Dr. John.
Oh my gosh, she won again. That's 2 in a row, 2 weeks in a row. No wonder you're a resident. Okay, very good.
Thank you.
Okay, congratulations. Okay, very good, Dr. Sabea. Before we close, do you have any? Do you have a topic for next?
Yeah, I will continue with these unusual spinal lesions. I have more to show. One of them is an intramedullary schwannoma. As we know, schwannomas are intradural, extramedullary, but this case is totally inside the cord. And people would actually wonder how come that you get schwannoma inside the cord. So this is one of the cases. I have also a case of enterogenous cysts, which is very rare. Also cases of intramedullary tuberculomas, and I have other lesions. So we'll continue with these rare, unusual spinal lesions, not because they are rare, because we need to discuss the common lesions, but these lesions can very much mimic all of these common diseases that we have, and we have to be aware of it, and we have to raise the suspicion index so that people will think about it.
Very good. Thank you very much, Dr. Sabaya. Thank you, Vidab, for helping out. And we'll see you next week. And stick around. We're going to network. Thank you very much, everybody.